Welcome to St. Luke's University Health Network Rehabilitation and Movement Science Grand Rounds for October 30th, 2024. Today we have Dr. Katie Wilkens with us talking about mechanical low back pain in patients with neurologic disorders. Dr. Wilkens graduated from University of Hartford with a Doctor of Physical Therapy, and more recently completed her Diplomat in Mechanical Diagnosis and Therapy, and therapy from the McKenzie Institute, which is a credential that fewer than 550 providers in the world possess. Also recently, she earned the title of Fellow of the Academy of Spine Physical Therapy. And she currently practices orthopedic physical therapy at St. Luke's University Health Network at our Hillcrest location. Katie focuses on the differential diagnosis of her patients in order to improve their lives most efficiently and effectively. As a reminder to everybody, please make sure that you scan the QR code or log in using the code on the left-hand side of your screen, and momentarily I will put it in the chat. If you're watching the recorded version, you're already in there. Make sure, no matter what, that you complete the quiz and the course evaluation at the end of this program in order to get the CE or CME credit that you deserve. So this is the statement of need, and the target audience is all providers. This is St. Luke's designation statement, and this is the disclosure information. The planners and presenters have nothing to disclose. And without further ado, I will turn this over to Dr. Wilkens.
All right. Thank you very much, Dr. Karaha. And if you haven't thanked Dr. Karaha for all that he does, please do. He does a lot for our network and our team. He'll say he's just doing his job, but he does far more than that. So thank you. All right, so today's learning objectives. My goal for today was to share with you a few ideas of how you can identify if the pain in front of you is mechanical or not, and determine if you would like to pursue treatment yourself or use a lifeline if you are working with a patient with a neurological diagnosis or disorder. I work in Hillcrest, which is in New Jersey. You don't need a passport to get there. It's nice this time of year. Big shout out to our Hillcrest team. We have unbelievable powerhouses in that plaza there. But one thing that's really, really awesome is the way that we're able to manage orthopedic issues in our neurological population and share throughout all departments. So there's a lot of emphasis there. So I just wanted to kind of extrapolate what we're doing there and share with you all what we're doing, and if it's of any help to you, whether you do have, a neuro and an ortho team to share with, or if you are just neuro but you're still seeing back pain, what you might be able to do. I surveyed a number of PTs who primarily treat the neurological population, and we have a lot of common questions, concerns, and interests, so I wanted to address those things today. So I'm being very specific. I keep saying mechanical low back pain. So what's mechanical low back pain? That's the most common type of back pain. It's characterized by pain that varies with physical activity, positions. Historically, it's recurrent, it's episodic. Sometimes it's self-resolving, oftentimes it's self-resolving, but it's not sinister. Okay, so as opposed to low back pain that may be non-mechanical, and we're going to talk about how to tease that out. So mechanical low back pain. So per our literature, there's 3 common risk factors to mechanical low back pain. One of them is related to having a history of low back pain. The number one predisposing factor for low back pain is a history of low back pain. The second class of risk factors are related to physical or biomechanical stresses, which are like prolonged or frequent bending or twisting. And postural stretches, which are high spinal loads or awkward postures and the frequency of such. The third class is related to more psychosocial component. Maybe these people are a little more sedentary or fear avoidant. You can argue this list. I could too, and you could chicken or the egg it. I'm with you on that, but that's what some of our literature tells us. Okay. As far as prognosis for mechanical low back pain, it's got a pretty good prognosis. It generally wants to get better, and frequently it does. The things that again, per our literature, tell us that limit the prognosis of mechanical low back pain are related to poor sitting posture and frequency of flexion. Okay, so now we have a little idea of what that looks like. Let's kind of link it back here. So we're talking about our neuropopulation. So again, I'm extrapolating from Hillcrest here. We see a lot of different patients come in with either a Parkinson's disorder, chronic or acute strokes. Maybe some of these patients have had a status change. They were hospitalized for something unrelated. They're deconditioned. They're wearing AFOs for any reason. We have our amputee programs, patients who are in wheelchairs, whether that's new to them because of a status change or they've been in a wheelchair for an overwhelming majority of their life because of a congenital diagnosis or a paraplegia. And then again, you see your dizziness patients. And I know you guys see so much more than that. But I can speak to these groups to a degree. When it comes to this population, low back pain is very common. It's also very limiting. Now, it's often linked to an increase in disability, a decrease in quality of life, reduces balance, reduces activity tolerance, increases the risk of falling, decreases postural stability, decreases sensory integration. Postural instability is further, related to aggravating gait disorders. And some research shows that sciatic nerve pain can affect the autonomic nervous system, that can negatively affect tone, other neurodiagnoses and symptoms. So, and if you're treating this population, you're like, I know that. But again, you think about, okay, if I could shut this low back pain down, which is creating an influx of these issues, right? Balance disorders, postural instability, all these issues that you're working on in your neuro goals, this pain is making those things worse. We want to target that. Now, I want to go back to the prognostic factors, okay? Low back pain, right? These are patients who have poor sitting posture or high frequency of flexion. Again, these things have been, in the literature, linked to a poor prognosis. But think about these patients who are donning and doffing AFOs regularly, spending a lot of time flexing, spend a little more time putting a prosthetic of their prosthesis on, bending forward. You're in a wheelchair, you're sitting pretty much all day. You might be able to change the tilt on that wheelchair, you may not be able to. But again, you're still in a similar position. Balance, writing reactions, and steadiness. These patients they're getting lower. They're leaning on stuff. They're on furniture. How many of these cuties roll in? You see their rollator like 20 minutes before they get in the building because they got that full elbow extension. They're locked in full elbow extension. They're completely bent over, and they're coming in hot. But again, they're using these assistive devices, whether they're using them correctly or not. Again, some of these patients are in a situation where their activities of daily living put them in different postures or stress them differently than someone who doesn't have a diagnosis similar to their own. So that's just kind of food for thought here. So again, let's talk mechanical versus not so mechanical. Mechanical pain is often correlated to a loss of motion. There is usually a change in range with a change in symptoms. Those two things can kind of correlate as well. There's often variability with these symptoms. Maybe they say, oh, it's here some days, it's there some days. But oftentimes changes in posture or position change their symptoms. Okay, so when I say loss of motion, I'm talking about like the loss of motion. I just drove an hour. I go to get out of the car and, oh my God, I'm a little stuck. I gotta get up here. Okay, but you get it back. You get it back. I'm not talking about like loss of motion because I have a contracture. That's the kind of loss of motion I'm talking about. Again, and you'll determine that through an exam and testing. But one thing I wanted to note was the concept of centralization, and this is going to come up in our next slide. Centralization is a phenomenon that is linked to mechanical low back pain. Patients can have symptoms that are of spinal source that are felt farther away from the spine. That could be down the leg. I know this picture, this looks like kind of like your run-of-the-mill, oh, that's my sciatic pain, right? People often say that. Not everybody comes in with this exact pattern, nor do they to fit this centralization bill. Some of these people might say, you know what, I got this pain in the right side of my low back. My foot feels like tingly or numb. It's just different. There's something, or my calf feels really tight. That might be it. That might be all there is. There's no like line connecting the back to the leg specifically. But like I say, if you're able to identify symptoms that are further down the leg or further away from the spine, that change when you change the position of the spine, you may very well be looking at mechanical low back pain. So again, non-mechanical low back pain, this isn't going to necessarily change with motion. If it does, you're probably not going to see a lasting response. Some of these things could be systemic. They could be referral from other body parts. We're going to discuss the big, bad, and ugly stuff shortly. But again, the big thing I want you to take away from this is kind of the pattern that mechanical pain will follow. And how do we tease that out from the rigidity I might see in my patients with Parkinson's, the tone that I might see in a patient that I'm treating that has cerebral palsy, or maybe it's following a stroke. But again, let's discuss how to tease that out, because those things may be present, but they might not actually be your pain generator. So, okay, so this slide. So I just want to put a preamble, like a little asterisk here. The emphasis for all of this, we want to be able to shut down this low back pain, or at least identify that we're able to, but the goal is 100% to continue to pursue their neuro goals. That's what they're coming to you for. That's what they want. I feel very often patients who are on a neuro caseload are working harder than half of my ortho caseload. These people dig in their work. They have serious goals that they're really passionate about. So to tell them, oh, we got to slow things down, we got to deviate away from the plan, it's gonna break hearts, and that's not fair, especially if we don't need to do that. So what I have here, I'm trying to emphasize being concise. This kind of suggestion that I have here for things to tackle, assess, and examine is not a be-all, end-all, and it is not an all or nothing exam or eval. Okay, keep the focus on neuro. It gives you an idea of how much time and effort you may end up investing before you refer, if at all necessary. Again, goal is to keep the neuro train on the tracks. I will say it is just as important to identify if the pain in front of you is mechanical as it is non-mechanical, because we got to get them to the right people. I want to just take note of this chart. Patients with mechanical low back pain have been shown to improve better, more, faster, efficiently, when they've been subclassified and then treated based on per their subclassification, and their treatment matches their needs or their diagnosis. So here's a chart that helps subclassify patients into a category for management based on symptom response, courtesy of the treatment-based classification system. As you can look, the first thing they're asking about is, can my patient's symptoms centralize? So that's why I wanted to emphasize the nature of that prior to jumping into this. Okay. So a couple things that you might want to collect, ask, talk about prior to, or when you're determining if the pain in front of you is mechanical or not. When did this begin? Something happened. You started something new. Yes, I was reaching for something in the back seat of the car. Oh, that got me. Okay, right, rotation. I was changing a light bulb. I was overhead. That thing was real stuck. Sustained extension. Okay. All right, I was feeding the cat. Forward flexion. Okay, that's going to give me a little bit of an idea. How many of these people are like, nope, came out of nowhere? All right, that's probably going to be more than half of the case. It could be just a result of cumulative stresses and postures and activities. So you want to kind of get an idea of what's their environment like? What are their leisure activities? What are the patterns they're doing? Yeah, I have a pretty long commute to work. I sit in front of a computer at work, but when I get home, I love to ride my bike. I love it. Great. Okay, but that's a lot of flexion. All right, that's what that tells me. It doesn't mean it's bad, but that just kind of gives me a little insight of where they're spending a lot of their time during their day. Okay, so like the location of symptoms, that's going to be really important, because again, it's going to help me to identify if I have symptoms that might centralize. It's also going to help me identify my pain, help me identify a pain phenotype. We'll discuss that later. Constant or intermittent symptoms. Intermittent symptoms can indicate that certain postures are helpful versus not so much, right? Do I have pain during an activity or after? My favorite is, yeah, I was really up in the ante in Rocksteady, and my back's bugging me. Okay, when during Rocksteady did it start bugging you? Well, it was after. How soon after? Well, like 2 hours later. Okay, what were you doing 2 hours later? Sitting on the couch having a sandwich. I'm a little more suspicious of the sandwich on the couch than I am Rocksteady. Okay, fine, but those are just things that I want to kind of keep in mind. I want a very clear idea. Is their overall status getting better, worse, staying the same? It's going to give me an idea of the nature of this. Is it regularly being aggravated? Is there an irritability or component to this? I want to have an idea. Because, the other thing is they might say, it's getting better. Okay, what have you been doing? I've been doing a ton of stretching. What kind of stretching have you been doing? I've been doing this. Okay, so whatever this is, that might actually be very helpful. Is there a way we can incorporate that a little bit more? Fine. So again, just being clear what their aggravating and relieving factors are going to be really helpful, and you're looking for patterns. I put here comparable signs. These are super, super, super important. These are going to tell you where they're at and what you're actually doing intervention-wise is effective. It kind of tells you what you're working with and gives you a way to direction. But the thing of it is, these comparable signs have to be relevant, have to be important to the patient. It might just be their resting pain, but it might be that, yeah, but when I do this during my chair yoga, that really lights it up. Make it specific, and it, like I say, it may be part of their program that they're doing in the clinic with you. Posture correction. If you're talking to this patient, they're telling you about this pain, and you ask them to correct their posture if it indeed is like maybe slouched or something. I can assume that because 90% of the people that I talk to when I take my history are pretty slouched when they're sitting. But if they're slouched and you ask them to sit up, hey, that feels different. Better, worse, or no different. No, that's better. Okay. What do we say? Mechanical pain is likely going to change if there is a change in your posture or you move. So again, a good indicator that this might be mechanical. I put here a neuro exam, and this is like this is debatable even in ortho world, right? Therapists have different ideas of when they're going to do a neuro screen or a neuro exam. And when I mean neuro exam, I mean I want to be sure that I've captured all of the symptoms. If I'm assuming that their sensation is totally normal throughout, and I don't test for it, but then later on they mention, like, what's funny? Like, I don't feel my big toe as much as I do on the other side. Well, how long has that been going for? I don't know. Maybe it's been there all along, but I didn't look for it. But again, some of our patients already have a sensory deficit that they're starting off with. Could this be different? Let's capture it. You've probably already gotten a baseline on eval. Let's see if that's changed at all. This is where we're talking about like tingling and numbness. Again, this is where you can kind of screen your dermatomes. You may grab a myotome, screen here, reflexes, straight leg raise, cross straight leg raise, slump. And again, that sounds like, yeah, that's going to take up like my whole session. This is not an all or nothing. This is not a be all end all. You might do one of those things. Great, that's fine. You may not need it. Like I said, these are just certain things that are going to be helpful in identifying your symptoms, where they're at, and how they respond to interventions. So these are just certain things that you can keep in mind. Okay, active range of motion. You want to collect your baseline first. You want to know, okay, I'm working with symptoms in this location and this location, or just exclusively in that right low back. You want to ask them if this motion is normal for them. You don't want to assume, actually, I could go farther. Really? Yeah, I used to be able to touch my toes. When was that? Last week or like back before NOM? Okay, we want to know like what's the reality of their mobility. Because if it is a little bit obstructed, we want to get them moving freely and comfortably in all directions. But again, for these patients who are having balance deficits, or some of them are not even able to tolerate being up on their feet without an extensive amount of support, so modify it. You might have to collect these baselines in sitting. You might be looking a little bit more thoracic. Lumbar spine's moving when you move the thoracic spine. You can argue that, but there's some motion there. But again, this might be, you have them in the parallel bars. Maybe they're in the solo step loosely if they feel like they're going to fall. You don't want them to be guarding. But there's lots of different ways to modify. When I talk about strength, yes, you might collect strength. Again, on your initial eval, you might collect strength information in your neuroscreen. But I'm curious about, people will ask about core strength. This might be the person that you've asked to correct their posture and they're holding it and they're losing it. It's like been 10 seconds. You're only on to like one question after the first one when you ask them to correct their posture and they've already lost it. That might be indicative of a weakness. This actually feels better, but they can't hold it. So it's not that it's pain that's getting them out of that position. They just can't hold it there. But its relevance to the pain might be indicative to the symptom feedback that you get in the moment. Okay. Function, again, this is where you're talking about some of these patients are coming in and they're really compensating, right? You see patients who have a big trunk sway. They're circumducting the right hip. If they don't have the strength to swing the leg forward and stay in the sagittal plane. Do they have a ton of pelvic rotation, big Trendelenburg? Asymmetries when they're taking different steps. Do they have decreased tolerance where they're kind of leaning on stuff? Their furniture leaning, their balance is so off, they're dizzy. They're constantly getting off their feet, so they're sitting a lot more. They're furniture walking. They're all over the place. But again, these are things that maybe had they not been dizzy, had they not been dealing with their dizziness? Have they not been in a situation where I can't really feel my feet, like I have a loss of sensation, now I can't try, like their balance is off. Okay, and then symptom response. Again, based on our flow sheet, it's asking, will do these symptoms centralize if I move this patient's spine? You can test that via repeated motions. I know you guys are waiting for that, right? Establish that comparable sign, right? You want to be clear and concise with what you're working with. Start with repeated motions in a direction that might be obstructed, but it's also opposite that of the direction that aggravates their symptoms. You want to retest their baselines after each set. You could do 10, 15, depending on the irritability. Some of these people might do like, you might have collected their active range of motion. They say, oh my God, that's terrible. Now I feel like I'm worse having done that. They might be really irritable. You might only do 5 repetitions with that patient. They're not fragile, but you want to be respectful of their pain limits. Some of these more chronic issues, though, they might be really stable and they might need more reps. They might need a little bit more to see a change. You may establish that flexion may not be painful for the patient, but overall they're getting worse. They've been stretching into flexion maybe. Yeah, I've been stretching my hamstrings a ton since this started. Overall, everything's just getting worse. Okay, so they told you they've been moving in one direction a lot more than normal. That's a ton of information for you to work with. Okay, you've been doing that. Let's look in a different direction. Patients might say, yeah, that made me worse. Well, was it worse when you were moving versus worse after it was done? Maybe it was uncomfortable while you're on the move, right? Some of these patients, oh, I don't want to bend this way, that hurts. It's really stiff. But after they're done, oh, I'm fine, no problem. Retest their baseline. Actually, that's a little bit better. Might want to run with that, but just respect what their pain's telling you. Sometimes patients will tell you, I feel better when I lay down. That might be somebody who will benefit from stretching unloaded. If patients have unilateral versus bilateral symptoms, right? I have that pain just on the right side of my low back. It goes kind of into my hip a little bit. That might be somebody that I approach more asymmetrically as opposed to somebody who has symptoms that are across the low back and go down into both legs, both hips. I may not approach that asymmetrically. I might approach that a little bit more symmetrically. But again, the goal is to try to test in positions that they can reproduce at home. And I think on the neuro caseload, you guys can be a lot more creative than most therapists. You guys are really genius with that. So again, just things that they can test and retest. So again, I just wanted to kind of give you this a little bit larger here. So if a patient centralizes with a set of motions, that might be all you need to do. You found a direction of preference, so you might just prescribe and include in your neuro treatment, go about your regular routine. That might literally be something that they come in, they stretch before you go through your program, you stretch afterwards, and that's it. That literally might be it. Again, the emphasis should be on what you're working with neuro. Their goals are the important ones. So it's not about necessarily, obviously if they're having pain, I'm sure they want that gone, but I've seen a lot of these patients who are like, no, it's no problem, it's fine, I can live with it, it's no problem. Well, it's slowing you down. But, so you kind of have to work with that. But so now, if you'll see here, right, so now maybe you've tried to move them and stretch them, and their symptoms really aren't centralizing. Maybe they're peripheralizing. And when I say centralize and peripheralize, centralize could also be, I have this right-sided low back pain. It kind of comes across, and then I do that stretch. Ooh, I only feel it in the middle now. I don't feel it off to the side. It might also be, I have pain that spreads all the way across my back. It kind of wraps around a little bit, and then I do the stretch, and ooh, it's kind of small. It's like localized now. Those are also indicators of centralization. So you might see that pattern. It might not be that, oh, I got symptoms out of my leg and it moved to my back. So quite the opposite. If you're seeing like, oh, they had midline pain and now all of a sudden they're saying, oh, wow, it's like really spread out across my back and I feel like something's going into my legs right now. That's peripheralizing. But that's when you might say, let me look here. This is where I might want to see, what about that cross straight leg raise I can grab? It's positive. That might be somebody who would benefit from traction. Somebody who is fitting a more hypermobile presentation, right? That straight leg raise goes to the moon. That might be somebody who benefits from a more stabilization-based treatment. And it may not be that they're doing a full transverse abdominal progression in your session. No, it may just be let's incorporate how you're engaging the core with the things that we're already doing in our neuro program. And holding it. Let's go from there. And if it needs to be broken down, it needs to be broken down. Absolutely. Like I said, this is not an all inclusive. If patients are more directed toward a manipulation care plan, right? These are the patients, maybe they centralize, maybe they don't, but they're a little bit more acute. They're not having symptoms below the knee. They might fit that. Again, based on your comfortability, your familiarity, that's per your discretion. And if you feel like you need help with that, and it might just be that an ortho sees them for 1 or 2 visits, assesses them, and that's it. It should not take away from your neurocare plan. But the biggest thing is if you're able to identify, again, that this is indeed mechanical and I can do one of these 4 things with them, I can keep the focus on neuro by all means. So say you move them, you're able to reduce their pain, they feel better, right? That's great. But again, like their neurodiagnoses aren't necessarily going away, right? Like their Parkinson's isn't going to go away. They're not going to have their stroke's not going to go away. The fact that they are paraplegic, they're going to be in a wheelchair. That's not going to change. But again, that's why it's all the more important to identify what pain is indeed mechanical and what is not. You want to prevent it from getting worse. You want to prevent it from getting worse, and you want to manage, again, give them as much independence in managing their symptoms as possible. Gives them an idea of how they can modify their environment to maximize and balance what stresses they're incorporating, which ones are helpful for them and which ones are not helpful for them. And some things are unavoidable, but I know what to do if I get in that unavoidable situation. Okay. We know like tone can fluctuate from medication or immune system. But again, if you can address the mechanical pain and they're just left with their tone, then we can say, okay, here's what I need to speak to the doctor about. Just simple as that. But let's go here. One thing we always get asked, so do I have to hold off on neuro until the back pain goes away? How much weight can they carry? It's like, should I not be putting weight on them while they have this back pain? Like, how much do I push them? And again, this is not a no pain, no gain type situation. I divert to the traffic light guide. Okay, if you're doing an activity and it feels good while you're doing it, do the thing. That's a green light thing. Let's go. Keep doing that. So if if these symptoms aren't coming on until like hours after your neuro treatment, it may not be the neuro treatment. It might be something that's going on afterwards. So again, no, I don't think you need to stop what you're doing, but let's find something to turn the volume down and incorporate it. Right. So we have green light activities. They feel good during, you feel good after. Yellow light activities, you might feel a little something going on while you're, if this is right, like when I'm doing my 3s and 4s during rock steady, I can feel it a little bit, but now that I'm done, no, I'm all right. I don't feel it anymore. It's fine. You go right back to your baseline. That's a yellow light activity. Just be mindful of it. Maybe something's got a pulse in there and we need to address it, but you just want to be respectful of that symptom. It's not necessarily making those patients worse. And red light activities are the things that, as you would imagine, they hurt while you're doing it and afterwards you hurt. This is I threw that punch. Ow, that hurt. It's been 20 minutes, it's still hurting. It's been 40 minutes, it's still hurting. Not the, again, no, I felt fine and it didn't show up until 2 hours later. All right, so those are red light activities. So when it comes to, do I stop doing neuro? Do I hold off on neuro until this feels better? If I have a paper cut on the back of my knuckle and I bend it, it reopens, right? But if I put a Band-Aid on it for a couple days, hold it straight, let the healing tissues bond together, I can take the Band-Aid off, bend that thing till kingdom come. So just break it down in your session. If you're feeling like there is something that's part of your session that's aggravating it, okay, maybe we modify temporarily, but by no means should that be off the table, especially if it's progressing them towards their goal. And again, this is kind of one where you want a no pain and no gain, KNOW pain, KNOW gain. But that, you might, if you're working with patients who have a more of a nociplastic pain phenotype, it's not mechanical. It's going to be, we're thinking a little more central sensitization, phantom limb pain. There's no identifiable nerve or tissue damage. There's more neuronal dysregulation. But again, it's not mechanical. Neuropathic pain, there is some damage to a peripheral or a central nerve, and radiculopathy is an example of that. And nociceptive pain is damage to somatic or visceral tissue, and that's mortar trauma or inflammation. That's more like your ankle sprain or you're, again, get out of the car, I'm stuck. Oh my God, I'm stuck. But we have to meet these patients where they're at. So understanding where they are based on how they move, right? The symptom isn't really changing, but this is also not red flaggish. We have to understand that if we're able to change some of their nociceptive pain, it might change the nociplastic component if it exists. So again, just kind of understanding where people are and again, meeting them where they're at. So I just wanted to go through a few examples of what this kind of looks like in the clinic. This was a 65-year-old female who, she has Parkinson's. She's a Rocksteady boxing participant. She's absolutely awesome. She had cataract surgery, so she was out for a month. She was pretty sedentary for the month, but she was recovering from that. So when she went to go back to Rocksteady, she was noticing, oh my gosh, my hip is killing me. Oh my gosh, my hip's killing me. I go to walk the dog, my hip is killing me. It's like a little bit in her buttock and her right hip. So she was concerned about that. This was also very painful when she was climbing stairs. She was taking anti-inflammatories twice a day, and she felt like she was not getting any better. Again, she was aggravated with Rocksteady boxing and twisting. So that was her history. So when we go through her comparable sign was she was standing, she couldn't really put full weight onto her right leg. She's sensitive in there. It's really sensitive in there. When I go up the stairs, it really, really hurts. She'd been leading with the other leg and kind of just following with the right. So when we looked at her posture correction, her pain was originally in her sit bone. She sat her up. She's like, oh, I don't feel it there anymore. It feels like it came up. It's more like, she kind of indicates like a little bit just above the SI joint. Okay, so it changed. It smells a little mechanical to me. Okay. I did a neuro screen on her sensation. I checked her sensation and a slump test for her. Her slump test was positive, and when I checked sensation, there was a little bit of variation in the thigh on the right side compared to the left, which she was completely unaware of. Okay, so then we looked at active range of motion. I did look at her hip. She had the tiniest bit of loss in her hip compared to her left, but it was not painful at all. Lumbar active range of motion, her flexion was within normal limits, but it was painful in her right hip. Her extension, she had a moderate loss and there was discomfort in the right buttock. Her right side glide and standing was within normal limits and it didn't have any effect. And when I say side glide, I mean I'm sliding the hips to the left and my shoulders are going to the right. I'm naming the slide for the superior vertebrae, so a right side glide would look hips to the left, shoulders to the right. Her right side glide was within normal limits and her left gave her some lateral hip discomfort. Little bit of weakness in the right hip flexor compared to the left. And from a functional standpoint, her mobility, she's taking very ginger steps, less weight bearing on the right than the left, no major compensation, but she was leaning forward. She's got that thoracic kyphosis and really didn't change at all. That's consistent with her Parkinson's presentation. I took her through a repeated motions test. She told me twisting, bending were her aggravating factors. So I started her an extension, repeated motions testing. I had her start with just repeated extension and standing. This thing's been going on. She told me she has a long history of low back pain. And that this was kind of newer, but it was newer in the last 2 weeks, but not crazy new. So I'm thinking this has happened before. So I had her extend, didn't really change, just do another set. I don't know, it's kind of the same. So I had her lean against something to increase the force. Maybe it's a little bit better, but she told me she feels better when she lies down. Her history, she said, I feel better when I lay down. I'm mostly flat when I lie down. So I got her off her feet. And she did much better when she lied down. She centralized, she got much better, she went back to Rocksteady boxing. But the point of this is that was one appointment, and what we did was that week, she was typically doing neuro PT 3 times a week. So week 1, I had one ortho visit with her and a follow-up visit with her, and then she went back to neuro later in the week. The week 2, she had 2 neuro appointments, 1 follow-up with me, and the week after that, she was just back to her regular 3 times a week neuro. She didn't have to stop anything, but what she did do is she would do her reductive stretches prior to Rocksteady. If she was feeling like her symptoms were aggravated, she would do it during Rocksteady on a water break, and then again afterwards. But this was, again, just having a conversation with the treating therapist. That was really beneficial. Okay, so she was a great example of Parkinson's, but she's super mobile, no major balance deficits. But this gentleman, he's been in a power wheelchair. He's in his mid-70s. He's complete paraplegic. He has left lumbar pain and he has some thoracic pain. He's been using biofreeze and lidocaine patches. He feels better when he sits upright. Thank you for that. That's very lovely. So that's the scoop with him. He comes in with resting pain, sitting in his wheelchair on the left side. Again, correct his posture, feels better. And it moved from the left side of his back to the middle of his back. Okay, great. I looked at active range of motion for him, but again, this was sitting. He is a mechanical transfer, so he was not sitting. So we looked at his lumbothoracic mobility. It's very limited in extension, very painful in flexion. His right rotation was very limited but not painful, but his left rotation was just fine. So that was his active range. From a strength standpoint, again, he was unable to maintain a corrected posture for seconds. He could get up there, and then it was maybe by second 12, he was already melting down. Function, same as leisure, again, right? Like he could tilt his wheelchair, but he's in the same position all day unless he's in the bed. So symptom response, he did very well. He had, again, such an inability to maintain that upright posture. So he was given some scapular strengthening exercises, just told to be more aware of his posture. He was given a lumbar roll, and he was stretching. He was doing a thoracic stretch as well. He came back 6 days later for his second visit, and he told his primary therapist he hadn't had any pain since his evaluation, and that was it. He was given a couple strengthening exercises. He was given a succession of bands that he could progress through. He did really well. But again, we didn't have to get him up. We didn't have to test all the 100 things because we just got enough of the ones that were able to indicate that it was indeed mechanical. Okay, this gentleman, this next patient, he has a long history of driving a truck, development of foot drop. He had a stroke many years ago, and he had a very, very mild foot drop as a result. But recently, he felt like his foot was slapping a lot more. Okay, so he went to the doctor, and the doctor said, well, you need an AFO. I'm going to send you to PT. So this patient was seen exclusively by a neuro PT. So he does have a history of back pain. So that therapist said, all right, let's move you. Posture correction had no effect on the foot drop. He just has stiffness in the low back, but really no change. Sensation was generally about the same. He has dorsiflexor weakness. He had plantar flexor weakness, but he did have a cross straight leg raise sign that was positive. Active range of motion in the lumbar spine. He had a major loss of extension. He stiffness throughout. Otherwise, he was like, this is just how I move. This is normal for me. Okay, it's been like that for years. Again, his strength was pretty decent throughout, aside from that foot and ankle. He was only very mildly compensating for that foot slap. He didn't have anything, going on like lumbar spine wise that looked like he was really deviating. But again, this therapist took him through some stretching. He had him stretch into extension. He had him stretch into extension off his feet. He had him flexing. He had him flex a ton. He even took him through some flexion rotation twisting. So he's looking to see if this patient will centralize. And again, if you go back to our chart, if they're peripheralizing or not improving with flexion and extension, this therapist said, all right, I'm going to pull on you a little bit. So he gave him a little bit of traction. Lo and behold, foot drop got a little bit better. So this gentleman, he ended up benefiting from traction and a little bit of stretching, but he was able to get himself back to where his foot drop had been, and he did not need to have an AFO. Okay, so there's just a couple examples, but again, I just want to reiterate that how do you know if it's not mechanical? The biggest thing, you want to rule it out or rule it in, but for the most part, if it's not mechanical, it's really not going to be affected by positions or postural changes, not going to be a loss of motion, or if there is and you regain it, not really changing their symptoms. There's no centralization or peripheralization. If there is, it's like kind of a fluke. It doesn't happen consistently, and it's not really sticking. But these are the patients you want to educate to the traffic light guide. You want to maximize their environment. Okay, what are things that are provoking your symptoms, or what are things that we know we can do to work in a safer zone? Again, if we're thinking like inflammation, chronic pain, if we're thinking tone, or meds, a lot of those osteoporosis and cholesterol medications have side effects of low back pain. So those are things you just kind of want to talk about too, because again, if it's not mechanical, that might be okay, I really think this is coming from a change in your tone. What are we able to do to modify that? But it kind of just helps streamline your care if you're thinking it's not mechanical. So again, you identifying that this isn't mechanical is just as important as identifying that it is. You want to get them to the right place. What's the next step? We have a multidisciplinary team. Alex Stiverson did a presentation on this earlier in the year about just don't forget where, don't forget some of these other people on our team. Do we need to talk to an advanced spine practitioner? Do we need to see rheumatology? Do we need to talk to pain management for this patient? Do they just need to exercise in general? Do they just need to get their heart rate up? Because again, they were deconditioned, get it moving, but we just know that we're exercising in a certain set of parameters and they know it, because otherwise they're going home and they're saying, no pain, no gain, and I'm going to work really hard. But in reality, they're slowing themselves down because they're aggravating their symptoms. We get asked often, so when should I send this to ortho PT? You can send it to ortho PT anytime. It's never like a burden by any means. It's not a grab at like a direct access eval. If it is, you can split that, But it might only be 1 or 2 visits. It might only be because the goal is, again, to keep them doing what they're doing in neuro. I don't want to take away from neuro when they can be doing, if they need only 1 or 2 things, they can do those before or after neuro, turn it into a home program, and maybe we follow up every couple of weeks. But you're going to just have to have an open dialogue between primary therapists. But again, if we're just ruling in, ruling out, it's important to, you might send them to ortho to say, listen, I think this is what's going on. Can you just confirm that or tell me how I can progress this? Great. And then send them, they go back. Great. If you're not feeling comfortable or confident with, an intervention and you need help, that's fine. Like I say, it might be something that only needs to be done a few times. But again, note that orthotherapist needs to know that their neuro goals are absolutely top priority. And, we want to hear it from you guys, specifically what we need to, about that. So that's super important. If you do say, hey, I think this is mechanical, I feel like I can treat this, I can feel like I can easily incorporate this into my care plan and it's not going to digress from what I'm actually trying to incorporate here in my neuro treatment, great. You might do a reeval, add a code, right? Add your diagnosis code like a lumbar radiculopathy or low back pain. You might you're going to update their goals. If you don't and you feel like I need somebody to look at this, but I want to get them back, if they're in the same region, you can share the auth with that. So that's just something to kind of think about. And again, today's presentation is it's just like a drop in the bucket of what's actually available, right? Some of these patients might have a mechanical component, but you can't see it because something's getting aggravated too regularly. Maybe these patients need some intervention like soft tissue. They might need more dry needling, maybe the cupping. If there was a REPEX table in the network, they could benefit from that, because that's one of the biggest things is some of these patients don't have the strength to get into as far enough of a stretch as they need. But there's so many options. So again, if it isn't mechanical, I can give you an example. Have a patient, he was post-stroke. He was so hypertonic throughout the entire affected side. He was so locked up. And I couldn't change it. I moved him in a bunch of different directions. I could not change his symptoms. We tried numerous things. But by visit 3, I knew, or I felt very confident at least, that his symptoms were not coming from a mechanical source that I could change. But we got back to his doctor and he was able to manage his tone with his medications, but I didn't spend 4 to 6 weeks like, well, we're going to stretch a whole bunch of this stuff because it all looks tight to me. No, he got back to his doctor and within a week, things got a lot more regulated. He was able to be more comfortable. So that's why I say it's so important to know if it is mechanical or not. Another example, again, gentleman, he has chronic inflammatory polyneuropathy, really interesting gentleman, bilateral extremities. He was hospitalized, and after that he was a serious deficit for strength in his legs. He went from walking with AFOs and a walker to AFOs, 2 walking sticks, AFOs and a cane. He's no longer walking with a cane and he's trying to ditch the AFOs. Let's go, which is awesome. This guy works, but he's progressing himself pretty fast and he's pushing himself pretty hard at home. So he's taking AFOs off and he's doing all of the laundry and he's doing all kinds of stuff, but his back is aggravating him like constantly. But he doesn't want to stop what he's doing. He doesn't want to stop his progression. He came in, he was treated. He does have a mechanical component, but he's consistently aggravating it at home. I don't want to tell him to stop doing what he's doing. He's very aware that his push is aggravating his symptom, right? We go back to the traffic light guide. He's doing things that provoke, increase, or produce his symptoms, and he remains worse as a result. So it's technically a red light thing. If he does less, he doesn't get his pain, but he doesn't want to do less. So he was someone who benefited from a lot of education. He did end up seeing pain management. And when he got to pain management, the doctor gave him his options. He was like, I don't need a shot. I feel fine. He was like very okay with having like this 1 out of 10 pain. He didn't feel like he wanted a shot. But again, that presentation isn't common, but that's where you kind of help establish some of those parameters to work in. We get asked this like, okay, when do I refer out because I see something big, bad, and scary? I can do a little bit of math here real quick, which I take my shoes off for that, use the toes. Spinal fracture, cancer, osteomyelitis, cauda equina, ankylosing spondylitis, cardiac disease, myelopathy. All these things, big, bad, scary, ugly, right? But they can manifest as low back pain, but their prevalence, the percentage that we will see them all in combination is less than 2%. So the chances of it being big, bad, and scary are on the low side. By no means impossible, of course, but again, if it's mechanical, we're going to move them. Something's going to change. We're going to see those things that we've just been talking about. These scary things are likely not going to respond to that. So that's how you can kind of have an idea. Again, some of those red flag signs that people ask about, are you seeing progressive motor or sensory loss? Again, progressive, not this is what I came in with after my stroke. This is what this was the deficit I had originally. This is what originally brought me here. New urinary retention or overflow incontinence. Again, new. And then, we talk about red flags too. Red flags are a little bit more red when in combination. So those are the people where you're looking at, like they've had the history of cancer or an invasive spinal procedure recently or a significant trauma related to their age. But again, positions and postures won't often change those things. We can talk a little bit more about that. But again, so why does all this matter? Again, we talked about this. Patients who are working towards neuro goals and balance goals, the things that are limiting them from feeling like they're back to their prior level of function often get exacerbated when low back pain is added into the mix. So we really want to keep that from slowing things down. Again, it's the obvious, their quality of life, dependency on caregivers, maximized. But even more so, the history of low back pain is recurrent and episodic. So if you can give them something that turns the volume down or off, it may also be the thing that prevents it from coming back. So you could spare them a whole bunch of headaches. Well, not headaches, but low back pain. But I think that's exceptionally valuable. So again, today was kind of like I wanted to kind of just take some of the things that are helpful for us, again, out by Hillcrest. These are kind of the things that we are looking at. Again, it is not an all or nothing list. It's not a be all end all list. There's plenty of other things, but again, if you can identify if your symptoms in front of you are mechanical, phenomenal, because if you can invest that kind of interest, your patients are better off for it. I'm happy to discuss this further. I know we're running out of time, but please feel free to reach out to me on Teams or email. Happy to have the conversation. But if there are any questions, I'm happy to answer them. Yes, sir.
So there is one question, and just before I state this question, please, if you want to ask a question, either unmute yourself and ask, or type it into the chat, and I will read it. So the question typed in the chat is, do you have any recent case examples of working with patients in the neuro population looking at mechanical extremity evaluation?
Oh, yes. Yes. And without getting too in the weeds, mechanical extremities will respond to changes in position or posture. If you move them in a certain direction and you are able to gain lost motion, they can respond very similarly. It truly, when I treat an extremity, I think, okay, what would I do if I was treating the low back? So the patterns are very, very similar. So it's there. It's totally there. That's a great question. It's 100% there. Send me a message on Teams. We'll talk. All right. Thank you so very much for your time. Thank you so much to the therapists who were able to kind of help me out with surveys and questions. I was picking brains left and right, but really appreciate it. And again, huge shout out to our Hillcrest team. They rock stars. They make this very possible. So thank you so much for your time. Really appreciate it.
Does anybody else have any other questions? All right. Again, please remember to complete the quiz and the course evaluation so that you can get your CE or CME credit. Thank you very much, and we'll see you next